This is Dr. Julie Huffmeyer with our Open Anesthesia Intraoperative TEE Case of the Month for March 2012. Each month we feature an operative case which teaches or emphasizes an important aspect of basic intraoperative TEE. This month we present the case of a 24-year-old woman with a past medical history of tetralogy of Fallot. Other than her congenital heart disease, our patient had been healthy, fairly active, and she had recently completed her college education. She had undergone 3 previous sternotomies for repair of her congenital heart disease, including a central shunt, which subsequently became occluded, followed by a left Blalock-Taussig shunt as an infant. Then at 4 years of age, she underwent a formal tetralogy of Fallot repair with ventricular septal defect closure and patch augmentation of her pulmonary artery. Our patient complained of increasing dyspnea on exertion, especially over the last 6 months. Going up just 1 flight of stairs caused her to be significantly winded. Her transthoracic echocardiogram revealed moderate to severe residual pulmonary stenosis with moderate to severe pulmonary insufficiency. The peak gradient across her pulmonary valve was found to be 80 millimeters of mercury, with a mean gradient of 46 millimeters of mercury. She was also noted to have significant right ventricular hypertrophy and dilation, as well as dilation of her pulmonary artery. Her left ventricular function was normal. She presents for pulmonary valve replacement via her 4th open sternotomy. These are side-by-side images of our patient's right and left ventricles as labeled. This is a 4-chamber view at 0 degrees, although both atria are not completely imaged. Even though both ventricles are not shown in their entirety, it is important to notice that her right ventricle is dilated and hypertrophied or thickened and makes up part of the ventricular apex. Normally, the right ventricle is ellipsoid or crescentic in shape, making up only 2/3 the length of the left ventricle. Color flow is placed across the interventricular septum in order to evaluate the previous patch repair of our patient's VSD as a child. From this view, there is no remaining patent VSD. This is a transgastric mid-papillary short-axis view of the right and left ventricles. Our patient's left ventricular function is well preserved, but her right ventricle appears dilated with mildly reduced function. Here's a graphical representation of a normal heart on the left and a heart with tetralogy of Fallot on the right for comparison. The 4 classic elements are membranous ventricular septal defect, pulmonary stenosis, right ventricular hypertrophy, and overriding aorta. The severity of the defects and distinct anatomy can vary considerably from patient to patient. One of the elements that is inconsistently represented is the right ventricular outflow obstruction. Some patients have infundibular hypoplasia in the subpulmonic area on the right ventricular side of the pulmonary valve. Others have true pulmonary stenosis at the level of the valve, and others have obstruction of right-sided outflow distal to the pulmonary valve in the main pulmonary artery. Other cardiac defects that are associated with tetralogy of Fallot include additional VSDs that are most commonly found in the muscular ventricular septum, a right-sided aortic arch, and an anomalous origin of the left anterior descending artery from the right coronary artery. This causes the left anterior descending artery to course across the right ventricular epicardium, which makes for a very challenging surgical approach to the right ventricular outflow tract. Other less common associations are complete AV canal, anomalous pulmonary venous drainage, and dextrocardia. The physiology of tetralogy of Fallot is complex, and the unrepaired patient is cyanotic. Due to the right ventricular outflow obstruction, there is insufficient pulmonary blood flow. Oxygenated and deoxygenated blood mix across the VSD, and blood typically shunts from right to left. Pulmonary vascular resistance is normal or low, and right to left shunting is unaffected by manipulation of the pulmonary vascular resistance. Shunting is affected instead by altering the systemic vascular resistance. Thus, increasing the systemic vascular resistance forces more blood through the pulmonary system, and it has an opportunity to then become oxygenated, and systemic hypoxemia decreases. A TET spell is a hypercyanotic spell occurring in patients with unrepaired tetralogy of Fallot. It is triggered by a decrease in systemic vascular resistance or spasm of the right ventricular outflow tract. This results in an increase in the magnitude of right-to-left shunting and worsens hypoxia as it decreases pulmonary blood flow. Appropriate treatment of a TET spell depends on the cause. In cases of decreased SVR, an alpha agonist such as phenylephrine is used to increase SVR and force more blood into the pulmonary circulation. An IV fluid bolus is used to increase preload and distend the right ventricular outflow tract. Infundibular spasm or right ventricular outflow tract irritability is treated with propranolol or esmolol. Oxygen and sedation are also interventions that will help to treat TET spells. Interestingly, for reasons that are not well understood, TET spells occur in children and are not usually seen in older, unrepaired patients or adults. This is the view of the aortic valve as labeled on the left side of the image and the pulmonary valve and pulmonary artery on the right side of the TEE. The right ventricular outflow tract appears to be stenotic here at the level of the pulmonary valve. Remember, our patient had a transannular patch placed to widen her pulmonary artery as a child, but this is difficult to visualize via TEE. This is the same view at approximately 60-degree multiplane angle, with color flow placed across the right ventricular outflow tract and pulmonary valve. There is obvious turbulence of blood flow from the various hues and speckling of the color flow pattern. This signifies that the blood is accelerating to get through a smaller orifice, and in addition there is also regurgitant or backward flow of blood noted through the pulmonary valve into the right ventricle. This is a continuous wave Doppler interrogation of our patient's pulmonary valve and right ventricular outflow tract. By using continuous wave Doppler, the highest velocity will be sampled, and thus this will be at the area with the most narrow orifice, or the area which is most stenotic. Here, our patient has a peak gradient of 54 millimeters of mercury across her pulmonary valve. Remember, when our patient had her preoperative TTE, she had a peak gradient of 80 millimeters of mercury across her pulmonary valve. Often these peak gradients are reduced under general anesthesia with controlled ventilation and 100% inspired oxygen. Historically, patients with tetralogy of Fallot underwent palliative shunting in order to provide for more pulmonary blood flow and oxygenation. As surgical repair and technology have improved, children typically undergo complete repair in early infancy. Our patient had a central shunt followed by a Blalock-Taussig shunt or a BT shunt placed as an infant in order to increase her pulmonary blood flow. A classic BT shunt involves anastomosis of the right subclavian artery to the pulmonary artery. A Gore-Tex graft may also be used to create a BT shunt, and shunting can then be done from the left-sided vessels. The ultimate goal of a BT shunt is to bypass the right ventricular outflow tract to provide pulmonary blood flow, which then goes to the left heart and is ejected as systemic cardiac output. A complete repair involves closure of the VSD and repair of the pulmonary stenosis to relieve the right ventricular outflow tract obstruction. The patient's native anatomy will determine the course of action across the right ventricular outflow tract. Often, as in our patient's case, a transannular patch is necessary to widen the right ventricular outflow tract and pulmonary artery. Repair of the pulmonary stenosis with a transannular patch leaves a tetralogy of Fallot patient with pulmonary insufficiency. This is usually well tolerated for some time, up to many years. Eventually, chronic volume overload of the right ventricle becomes problematic, and patients develop right ventricular dysfunction, exercise intolerance, and dyspnea like our patient. In addition, conduction disturbances and ventricular arrhythmias may result from repair of tetralogy of Fallot. Our patient underwent a pulmonary valve replacement with a 25 mm porcine valve conduit. The distal portion of the conduit was anastomosed near the branch pulmonary arteries. The proximal portion of the conduit was more challenging to anastomose, and the right ventricular outflow tract required some resection of muscle bands in order to get a stable anastomosis. This is the side-by-side view with and without color flow, showing the right ventricular outflow tract and the new pulmonary valve conduit. It appears widely patent, and there is some turbulence of flow noted, but not nearly as much as in the preoperative echocardiogram. This is a continuous wave Doppler velocity profile across the new pulmonary valve, showing a peak gradient of 22 millimeters of mercury. Remember, our patient's preoperative peak gradient in the operating room was 54 millimeters of mercury, so this is an improvement. She had a full recovery and showed significant improvement in her symptoms. In summary, adults with repaired congenital heart disease represent a growing population of patients in the United States. Tetralogy of Fallot is a common cause of congenital heart disease and encompasses 4 elements: ventricular septal defect, overriding aorta, pulmonary stenosis, and right ventricular hypertrophy. In the past, repair of tetralogy of Fallot initially focused on palliative shunting, but currently definitive repair is accomplished earlier in childhood, most commonly during infancy. Common problems encountered remotely after repair include pulmonary insufficiency, conduction disturbances, and arrhythmias. TEE is helpful during revision of tetralogy of Fallot repair to assess the quality of repair, any residual stenosis or insufficiency of valvular structures, and may also be used in non-cardiac surgery cases for adults who have repaired congenital heart disease to evaluate cardiac filling and myocardial function.